Our facilities have never stopped. We were firm believers that if these people don't get seen, they're going to get major complications, and then they're going to be in the hospital twice as long. We never closed our offices down completely, especially for the wound patients. We had to keep seeing them. The wound centers in the hospital didn't close because that's what kept people out of the hospital and from using up needed beds. So, wow, it was so busy during COVID. Probably in our one hospital, we had over 50 people on service at one time, and they were all wounds, abscess, bone infection that required debridements and partial amputations, and then you have to pack them, put a wound vac on, do things of that nature, and then go back and do some kind of a definitive procedure. So that was probably the biggest challenge, is getting people to understand that their process, the disease process they have right now, because diabetes was a major complication for COVID especially. 39% of people that I believe died from COVID were diabetic, so that they needed to be seen so that we could keep them out of the hospital. That's why amputation rates are up 11-fold, because people were not coming in and being seen. Diabetes is a chronic inflammatory state which affects every system in your body. So therefore you have that low-grade percolating sterile inflammation throughout your body that only gets amplified because of that virus. So it was I told them it's a very personal discussion that you want to have with you and your physician, but as a diabetic, you should be very inclined to have your vaccination. And one of the biggest problems we had was there was no valet service at the hospital. So a lot of these older people would come, and then because they can't walk long distances from the parking garage to get into the wound center. So we had to reinstitute that process so that they could get their car, and the guys could take their car and park for it, so they could just get out, get in a wheelchair, and get to. And so that was a big challenge too, because people didn't want to come because they couldn't walk the long distance from the parking garage into the hospital. That was a big problem. You would think of that being very superficial, but it was not. That was a very significant problem that we had to fix, because otherwise they weren't coming. So transportation issues and affordability of that transportation was a problem, but our system was very keen in helping that. The biggest wish list that we have is for people to come to get seen. Diabetic foot ulceration, 47% mortality rate, chronic venous leg, all-cause mortality of 30%. If people do not come and get treated and have the proper treatment through our limb salvage team, because it takes a team to treat these people, they are going to get major complications. That's why the amputation rate is 11-fold. And even when you do get good proper treatment, there are sometimes people do get complications from their diabetes and from that chronic wound that's open. The longer it stays open, the greater the risk of the problem. Now they come because they haven't been seen. Now they're going to be in the hospital 2 to 3 times longer. We've had patients in for a month because of the complications that occur with blood flow, with kidneys, with infection, with bone infection, things that you have to do multiple debridements on before you can take them back, do a definitive procedure, and then get them out to a rehab institution that's going to take them too. Because that was also the problem. Some rehabs were taking patients, some rehabs were not taking patients because of the status of the patient with this virus. And you know, with diabetics, they have a multitude of antimicrobial resistant infections, MRSA, ESBL type bacteria, a lot of resistant Pseudomonas. So it was very difficult, depending on what they grew and what they were sensitive to get people placed in rehab facilities. And then that was another problem, was when they were going to the rehab facility, now they're on quarantine, how are they going to get back and see us? So how am I going to follow up and look at their incisions and look at, they got wound vac on, who's going to change that? That was another problem. Getting patients back. So there was times that we didn't see people for 14, 21 days after they got discharged from the hospital. Now they come back to the office. Now they got a complication. Now something's wet, dehisced, some kind of problem that's going. Now they go back into the hospital. So that was the confluence of care there was really resisted because of all of the quarantining. And if they came to us, then they go back. Now they left the facility. Do they have to quarantine more? Oh, what a nightmare that was to coordinate the care for those people. Chronic ulceration, because of the significant mortality rate that is associated, the significant cost that is associated with that, you can't forego your care. You need to be seen, you need to get in, you either get to the wound center or you get to the office, because that treatment in the wound center or the office will keep you 99% of the time out of the hospital. Do not forego your care. The mortality rates are too high. The hospitalization rates are too high. Now you're going to be using beds up that could have been offered for people that do have the complications from that. As a diabetic patient, you're at high risk for complications from COVID because of the chronic, smoldering, percolating inflammation that's coursing throughout your body. So discuss things with your doctor. If it's appropriate for you to have your vaccination, get that done because that will protect you and mitigate those complications of the virus. But I think it's important that you've got to get seen. Don't forgo your care. The cost is too high.